Yes? Okay. So thank you very much for coming to our EYFDM session this afternoon. So we're going to talk about challenges in family medicine. And I know it's such a sunny, nice day. It's the last session. I don't think we'll be here till 6. So you can look forward to the sun. Could you put up your hands if you are an EYFDM member? So 50%? Okay, great. So the people who are going to speak, it's me. So my name's Stuart. I'm from Northern Ireland and I work as a family doctor in Manchester. And as of this week, I'm the new president of EYFDM. And then and then after me, Daria. Or can we increase the volume maybe? Yeah. And then after me, Daria Gheorge from Romania and France is going to speak. And she's the French representative on the EYFDM Council. And then at the end, we'll hear from Ikbal, Humay, Arman. So Ikbal is on the EYFDM executive from Turkey, but she couldn't make it today, so she's going to speak by video. Okay, so the title of the session is Challenges in Family Medicine. And if you clicked the detail, it said Family Medicine is in Crisis. Let's find solutions together. So a little bit provocative title for a conference that's supposed to celebrate family medicine across Europe. But when we met as a group to talk about what we wanted to use this session, the Gold Hall for, we had a lot of the kind of frustrations that we wanted to air. And so we're going to give you our perspective on a few things. And then we want to get your feedback using Slido after each bit. So hopefully that all works to plan. So if you could take out your phones and we'll get started. If you go to the QR code, it should take you to this poll. And I suppose our first question for you is, where you work, is family medicine in crisis? Okay, so 80-20, okay. And I presume most of you are from Europe. Is there anyone from beyond Europe? Yeah, okay, great. Okay, and then the next question is, so what are the issues that are causing crisis in family medicine where you work? So recognition, GP shortage, workload, workforce. Okay. So it looks like workforce shortage and workload are probably the biggest things. So thank you for that. That resonates with what we were going to say. Who wants to become a GP? Okay. Yeah. Okay. Thank you for that. So what do we see as the challenges? So the three things we're going to focus on today are excess workload. I'll speak about that. And then Daria is going to speak about issues within our profession as a group of people, colleagues. And then Ikbal is going to speak about health inequalities. So those were the things that we wanted to raise. But we're going to try and be a bit positive too, and we'll use Slido to get your solutions. Okay? So hands up if you're from the UK. Okay, not too many. That's good, because I'm going to throw it under a bus. Yeah. So, so started my residency in family medicine in the UK in 2017, and since then it has felt like we're continually in a crisis of so much negativity around workload in particular. So here's just a few stats. So in the month of March this year, in England, which is a country of about 55 million, there were 15 million family doctor consultations in that month alone, and that's 14% more than the same month pre-pandemic. So it's a pretty big increase in 4 years, and that's in the background of a more gradual increase as the population has been growing and ageing. And that would be fine, except that as the consultation rate is increasing, the number of full-time equivalent family doctors is actually decreasing. It says there that since 2015, when this graph begins, there are actually 2,000 fewer full-time equivalent family doctors in England. And that is particularly depressing because there are more family medicine residents in the UK now than there ever have been. Like, they've literally turned on the taps, but people are retiring early, faster than they can be replaced by those of us who are coming through. And then, of course, that means that the number of patients per GP has been increasing. And for a full-time GP in the UK, it's currently 2,285. And then last week, when I was preparing this, I opened the British Journal of GP, which I don't always do, but it was fortuitous last week. And one of the articles that jumped out at me was Notes for a Profession in Difficulty by a group of young family doctors in London. And the first sentence is them asking themselves, is it me? Are we the problem? Or is it general practice? So I think that kind of sums it up, actually. It's frustrating because it's making people who are enthusiastic, well-trained, trying to do their best, they're not coping. And we're asking ourselves, are we the issue here, or is it systemic? Yeah. So the British approach to coping with the pressure is that we reduce the days we work, which then means there's less continuity, and then a worse service for patients. So I know that from being in WONCA and getting to know other systems, I know that in some places it's very strict and you have to work full-time, but in the UK, almost all GPs work quite flexibly, less than full-time. And in my year group of residents that finished in 2020, I can't actually think of anyone who's working more than 3 days per week as a family doctor. So that helps explain why there are so many trainees coming, but nobody is actually seeing patients every day. Yeah. And I can't speak for all British young family doctors, but for myself, I would work more if it was doable, we all like a bit more income, but I would be totally grey if I worked 5 days a week. So in the UK, are our best days behind us? So I know that within primary care world, we're considered to be quite a privileged country. We've had a fully universal free public healthcare system for 75 years. And we've had a College of Family Medicine for 70 years, which is, pretty, and we're the biggest college in the UK. There are lots of good things, but I can't help but think that things actually in the UK are going on a downward trajectory. It feels like we're only ever firefighting. Whenever something new comes along, we're too stressed to say yes. And I didn't realise that until I came to WONCA and learned about how things are in other countries, and kind of learned that innovations that come through that we say no, we can't, we're too busy. In other countries, you're taking it forward. So one of the examples, the best example of this that I think I'll talk about is PrEP. So that stands for pre-exposure prophylaxis. And it's a revolution in sexual health for gay men because you can take Truvada, the antiretroviral, on an as-required basis to more or less guarantee that you won't get HIV through sex. So that's amazing. it's not that complicated. But in the UK, that's firmly within sexual health services and secondary care. And I can't really imagine us, taking it on because we're too busy. But I was really pleasantly surprised that in many European countries, including Austria, the Netherlands, and Australia, not European, but we're going there next with WONCA, that in those countries GPs do prescribe PrEP for their patients. So on the one hand, it's really nice that they're able to do that, and also that they affirm the sexuality of their gay patients in that way. But on the other hand, it's a bit sad that I'm working in the UK and that I don't see this happening anytime soon. Yeah. So, who's going to come and work in the UK? Don't worry, I'm coming to Belgium too. Yeah, but what about solutions? Can you increase the volume? Okay, I'll try and stay close. So the solutions are probably don't lie in migration, but things are not so bad in the UK. We have become quite creative about how we deliver primary care to make up for the lack of family doctors. So the UK takes a very multidisciplinary approach to primary care. So with a laser-sharp focus on delegation of tasks. So practices in the UK are large organisations. If there are 5 doctors, there are probably 25 other staff. So I'll just quickly talk through them. So all practices have nurses who are trained to manage chronic diseases, including diagnosis and prescribing often for things like asthma, COPD, diabetes. Where I work, we have a pharmacist who does most of the reconciliation of medicines and manages the repeat prescribing. Sometimes we now have physiotherapists who can see directly patients with musculoskeletal problems rather than seeing a doctor first. And because we've got such big teams, we try and train them up so that they can read the letters from the hospital and things like that, so that we don't even see them anymore. And more controversially, the government is pushing other professional groups to do the role of a family doctor. So physician associates are a group that is being trained up to work in primary care. So I'm not saying that this isn't great, and it is a good approach to try and mitigate for the workload issues we're facing. But I don't know, this only works when you have family doctors in the centre driving the practice, and I feel that's where we're falling down. So that's the British approach to it. Could you take out your phones again, go to the Slido, and we'd be very interested to hear if workload is a crisis where you are, how is it being addressed? Yeah. So, multidisciplinarity again. Quitting, okay. Please no. Assistance for physicians, balanced group, work less. Oh, guys, don't quit. So, triage came up there a couple of times. Does anyone who has a good example of that, do they want to share, maybe? There are microphones in the corridors. Someone who put triage, do you want to share how that works where you are? Yeah, so there's a microphone in the corridor.
So, hello, I'm Maartje, I'm from the Netherlands. We have doctor's assistants that pick up the phone and do triage. It's been like this forever, so it's nothing new, but does help to divert patients from our consultations.
And where are they diverted to?
They give advice by themselves. They put it in our file, and we can say, "Oh, that was not correct," or "That is correct." They also tell the patients that they will consult with us, but then it will cost us just about 30 seconds instead of having a consultation for something that is not necessary. Also, there's some pilot going on in our city where the triage is being done digitally. So the patient has to go on the computer, fill in something about his, it's called, of course, you need to know for sure which patient you have. It's a digital ID. The computer asks if there's anything urgent going on. If so, the advice is call 911. If not, the computer starts asking questions about where it hurts or where is the spot, and can you load up a photo? So this is something new, and I do think it is something that will help us in a little bit, and better than what we have now, which is email consultations. And in email consultations, everyone can ask anything. Without having to put in any effort by themselves.
Okay, thank you. Okay, and does anyone have anything more constructive they want to say to the group? There were 20% of people who responded to the poll saying that family medicine isn't in crisis. So what are you guys doing differently? Please.
Hello. So I'm from Spain. It is true that the health system changes between the community we work in, but in mine, that it's the north part of the country, in the Basque country, there exists the triage, but with 3 different items that the people that work in the administration can do. So, for example, we have our planning year, the planning agenda, and there is always 2 places for a spontaneous consultation immediately that can be just released in the scenario that these 3 items become present. And then if there is an item that, like for example fever, and it's a child, we need to see them the same day. And so there are different places in the health center that act as an ER, but without complementary tests such as blood test or X-ray. It's only like a consultation, but without an agenda. So it's an easy consultation that works normally after 5 o'clock in the afternoon until 8 o'clock in the morning. So we meet at least these kind of urgent things. We do a triage by ourselves, and if we find that the patient needs to go to the ER, we send it.
Okay, thank you. And the woman over here?
Hi, I'm from Wales, UK, and our focus within primary care and urgent primary care has certainly been the multidisciplinary approach, but not just with nurses, physios, etc., managing chronic diseases, but also within advanced practice from nurses, midwives, physios, etc., and just wondered thoughts around that, because our advanced practitioners are certainly a key fundamental of our services currently.
So for people from outside the UK, so advanced nurse practitioners, are nurses who have done a master's, and they actually fulfill the role of a doctor quite closely. They haven't done family medicine residency, but they work at quite a high level. And I think I may be right in saying that particularly in rural areas, they complement the team of doctors. Is that fair?
I think all members of our team complement each other across the board. So having that multidisciplinary team approach with people picking the patients for their specialities has certainly helped in sustainability of our model within Wales.
Okay, thank you.
Thank you.
And last comment, and then we'll...
Hello, I'm a GP from the Netherlands, and I did not call it a crisis because the situation that we're in, I don't think it's a crisis because crises are worse than this. I've seen worse things in the tropics, and that are crises. As long as we call it a crisis, then I think the young GPs or the young doctors don't want to sort of help with this crisis, and we see numbers dropping in the study to become a GP in the Netherlands. So I think we should call it challenges. There's a beautiful healthcare system, and these challenges, we can just work on it.
I know where you're coming from, but I do find it hard to be, in the UK context anyway, it sometimes does feel like a crisis. Yeah, the fact that we're all reducing the amount we're working because we can't handle it, I feel that, I don't know, but I know you're coming, in the grand scheme of things, it's not so bad. Okay, so I'll leave you there, and Daria is going to speak about the next issue we want to talk about. So, Daria.
Good afternoon. Can you hear me? Okay, great. So good afternoon, everybody. My name is Daria Gheorge, and I am a young GP that is working in Strasbourg in the northeastern part of France. So what does the word challenge mean? So the Cambridge Dictionary actually defines it as being something that needs great mental or physical effort in order to be done successfully and therefore tests a person's ability. Challenges can come in all shapes and sizes. They can be a part of us, or they can be something that we actually encounter along our way. Take, for instance, this talk today. I really love to talk, but it also stressed me out a bit. But I'm sure that all of you has encountered at least once in their lifetime a challenge, be it professional or personal. There are also some challenges that unjustly arise because of where we are born. The differences are actually bigger when we look at European versus non-European countries, but it's also a problem in our own continent. Being born 100 kilometers to the east or to the south actually has a much larger impact than we could think on everything from your income to your health expectancy, life expectancy, and even gender gap. You can see here in the slide, on the left, it's life expectancy at birth, and the other one is the health expenditure per capita. So it's also a difference in how much countries are willing to spend for the healthcare. As Stuart mentioned in the beginning, I was born and raised in Romania, in southern Romania, but I am working actually in France. So the decision to leave the country was actually not an easy one. Is there amongst you in the room people who are working in a different country than the one they were born or trained in? If you can just raise your hands. Oh, my people, hi. Yeah, so for me, I really love Romania. It's the country where I was born, and I'm very grateful to all that it has given me. But the reason that I left, and it wasn't an easy choice, was to be able to provide my patients with the care and the means that I have actually learned about and not feel frustrated about it. Romania has come a long way since actually I have left, and my colleagues, the young doctors who are there, are actually doing work like step by step, but it's still baby steps for now. Sorry. Well, yeah. This is a poem that I wanted to share with you. What I said in the beginning does not mean that in France everything is just roses and rainbows. As Stuart has mentioned about the workload difficulties in the UK, there's also a problem in France as well. We're not enough doctors, we are overworked. We consider ourselves as being underpaid for the amount of work that we put in. We also might face patient aggressiveness and sometimes misunderstanding from the government bodies. The challenges I want to talk to you about today, I think you maybe noticed that they're a bit different. So there are challenges of being a foreigner, immigrant, expat. The word is the same, but the meaning behind it, the words might be different, but the meaning behind it is actually the same. It's not something very easy to just like uproot your life, go someplace else. It can be very difficult in the beginning. You feel that you don't have roots. You don't know if you have a home, if you have two, if you have actually none. And you start to miss the country you were actually so excited in the beginning to leave. From a personal point of view, it's also difficult. You have like a lot of administrative paperwork. You need to find an apartment. You even have to get used to different foods in the supermarket as well that you don't know. And from a professional point of view, it's not easy either. You have to get used to a lot of things, starting from like the easier basic things like the computer schedule, the computer program that they use in practices or in hospitals, until more complex ones. Like, for instance, in France, the system is pretty complex. We have like a lot of different pieces of a puzzle, and it's a lot of things that you have to learn. We are also faced, when we are working in a country that is not our own, with different attitudes from our colleagues or from our patients. Sometimes these attitudes can be really nice and welcoming, and sometimes not as much. You might have sometimes overheard the remark that your accent is not as it should be, or the word you pronounced isn't actually correct. You feel that you have to work twice as hard to prove that you're worthy and that you're actually worth to be there and you know what you're doing. Colleagues as well as patients might question your credentials when they find out that you're actually not born or not trained in the country where you are working from, where you're working in. There are sometimes colleagues who might say that you chose the easier way because instead of being trained in the country that you work in, you were trained in a different one, and sometimes they feel that that training is a bit subpar and not as difficult to get into. I wouldn't actually say that leaving your formal life behind and going to a different country is the easier way, but I guess to each their own. Sometimes there are also backhanded compliments. I don't know if it rings a bell for any of you. They would say some things like, "Oh, you're very good for a Romanian doctor," or, "Oh, yeah, like, oh, I'm not talking about you, I'm talking about the other Romanians." Well, if you actually insult, like, my people, it's not that very nice of a compliment, is it? And I also assisted sometimes at discussions when colleagues or doctors or nurses would talk about a certain doctor who is foreign as being the doctor from insert country. So no first name, no last name. We are actually taught as doctors to be really mindful about this when it comes to our patients. So not say the patient with Crohn's disease or the patient in room 402, but to mention by their first or last name. I think we should also try and think of being mindful as well with our colleagues. There's also the attitude of some patients. For instance, if you do not reply in the way that they expect you to, for instance, they ask you for a prescription that you refuse to offer for whatever reason, or if they find you're like a bit too, maybe too closed off or not open enough, it's not because you as a person are more closed off, it's because you are from that country. So for instance, if I am not very talkative, it's not because Daria is not talkative, it's because all the Romanians are not talkative. So you kind of become the ambassador of your country, something you never actually wanted in the beginning. But it's not all bad. I mean, I have had amazing, amazing colleagues, but these are just some things that I might have been confronted with. Some of you might have been confronted with that as well. It's even easier when, it's even more difficult, when there are also different factors involved, such as religion or skin color. And I'm not just a foreign doctor, I'm also a woman as well. So it's not easy being a woman either. How many of you women in the room have ever been mistaken with a nurse? Yeah, I thought so. So this is unfortunately something that happens on a regular basis. Nurses do an amazing job and they should be valued for it. But it is considered by definition a more female profession, whereas the males are supposed to be doctors. But as you can see in these statistics that are from 2016, nowadays the numbers are more or less the same. But in 2016, you can see that in a lot of countries, the majority of doctors were actually female. But despite of that, we're sometimes not actually seen as doctor material. We have also have sometimes struggles with inappropriate comments from patients, be it of a sexual kind of nature or some more invasive questions that our male colleagues are not necessarily subjected to. For instance, if we're married, if we have children, and all of these things that I guess all of you have encountered at one point as well. There is something also very specific to the French language. Are there any French-speaking attendees in the room? Okay, great. Well, I will translate it to English as well. So we have obviously the term doctor, so docteur, and usually patients, when it comes to a male doctor, they always address him by the title doctor. But when it comes to a female doctor, I have actually been asked a lot of times, how would I want them to address me, be it like madame, mademoiselle, like ma'am, instead of doctor. I usually say that doctor is fine as well if they want to, but it's not something that men are actually confronted with. Another problem is that since the profession is becoming more increasingly feminine, women get blamed for changes in mentality. For instance, the workload discussion that we were talking about, the fact that both men and female want also some time for our personal life, for our self-care as well, it's often associated with the fact that there are more women today working as doctors than there used to be in the past, and that we want to have children. So it's, it's like, you cannot be a doctor. What about your vocation? You're supposed to really be into this like 100%. How can you be a doctor, like a proper one, if you choose to work less hours because you want to have children? But on the other side, if you're actually really dedicated to your career and you work long hours and you don't want to have children, it's not good either. I mean, you're a woman, you're supposed to have children, so we can never actually win. But all is not lost, because we bloom where we are planted. And the key message of all of this, despite how dark it might have seemed in the beginning, is actually hope. For instance, like when I said that you have to work twice as hard, yeah, you take all of that hard work and actually you become the best version of a medical doctor you can actually be. And you realize that the fact that you have an accent is not a problem. It never was a problem. It's actually proof that you can speak multiple languages, and it's something you should be very proud about. Distance as well. We have all been like in a room and we felt like we were like 1,000 miles away. It's not the fact that you're not physically present with your family, that you cannot be there for them. And the fact that you live in a different country makes you have not one home, but two, and you become the bridge in between these countries. Also, we often focus on the negative parts or like the disadvantages of being a woman, but there are also like so many wonderful parts, and we have like so many qualities, and we should also focus on that as well. And we should, I think, take like all that anger and frustration when we see like related to gender gap and to comments, and really try to make a change, break the glass ceiling, and like provide empowerment for our female GP colleagues, but also for our patients. And like the last thing, what I said in the beginning, like the definition of challenge, it does not at any point talk about failure. So it's just about resilience and about tackling challenges. Thank you. Oh, it's supposed to be like that? So back to Slido. I would want you to answer the following question. Have you been discriminated against by medical colleagues? When I'm talking about this, you can either feel discriminated because of your nationality, race, gender. Oh, okay. Interesting results. Okay, I think most of the people have answered by now. Okay. Do you think that you might discriminated against medical colleagues yourself? Be it gender or otherwise? You could have, I mean, when I'm asking the question, it's not if you voluntarily did it, it's also if you might have done it and then looking back have thought, oh, maybe that comment towards that my female colleague was not actually what it was supposed to be. Okay. Good job, good job. So now I would like to hear a bit from you on how we can actually help create a more inclusive workforce. So what do you think? Okay. Listening to each other, awareness, communication, good leadership, team building. Okay. Awareness comes up a lot, tolerance, open-minded, communication. Oh, love. Oh, that's so sweet. Okay. This is a good one. Courage to challenge discrimination when you see it. Okay, okay. Does any one of you would maybe like to share your experience? If you have been either on the receiving end of discrimination or either on the end that might have done something without necessarily wanting to? No? Oh?
Hi, I'm Sharon. I am currently a medical student. I'm originally from Taiwan. Well, I'm Taiwanese Canadian, and I'm currently doing my medical degree in Poland. So I just wanted to add to your previous slide that, even because I saw a lot of people raise their hand when you asked if people are not working in the country they're originally from, is that we didn't get to choose our original family because we were born into it, but because we're living in a foreign country, we actually get to build our own family, and then we get to choose the people that actually accept us as who we are, and we get to build our own. So I think that's actually, it's tough, but it's also not a bad thing. Talking about a more inclusive workforce, I'm still in school right now, but for example, my school, I am the president of a Taiwanese student association, and so we regularly organize events to share about our culture, and we also encourage students. So now we also have students from India sharing about their culture, and from Thailand or Norwegians and other Scandinavian countries such as Swedish students. And yeah, I think it's great because diversity is power, and by being more open-minded, it actually gives us more opportunities to learn about, for example, here. I think by attending this conference, we get to see different aspects, and we get to see the pros and cons of different culture or different countries' approach towards healthcare, and that makes us even better physicians because nowadays with the convenience of traveling, our patients are from everywhere, and by being open-minded and learning constantly, this makes us better physicians. Yeah.
Thank you very much. Does somebody else have anything else they would want to share? Somebody that is working currently in another country than their own, who might want to share why and how that experience has been like? Or not, it's up to you. Okay, we have still... Okay. Thank you all for all your answers. Just leave it a bit more, and then we have one last Slido question that I want to ask you. Okay. Now it's a even more concrete question than the previous one. After all of that we discussed and like all the answers that you previously saw, what do you think that you can actually implement when you get back home after the WONCA event? Oh, organize an exchange. That's a good idea. Not work so much. Oh. It joins the previous topic. Okay. Team building. Organize an exchange again. Reflect on it. Colleagues, be grateful. Go to Latvia. See, some of you are using Slido to like promote things like exchanges or your own countries. Okay. Food exchange. Good as well. Anyone that would maybe want to tell us what's like a more expanded version of what you think you can like practically do, like apply next week or soon? No? Okay. Okay, thank you very much. I'm dying. So warm. Thank you. Oh, God. Oh, my microphone is still on. I think that's why yours is not working.
Do you want to introduce it? Okay. So far, so good with the technology. So our third speaker is another very active member of EYFDM called Ikbal. She lives in southeast of Turkey, and because of the earthquake, she's not able to get the visas. So she's going to speak to us by video message. So hopefully the sound will work, and I'll come back up for the Slido when that's done.
Hello everyone, my dear colleagues, dear EYFDM family. My name is Ikbal Humay Arman. I am the current EYFDM events officer. I'm a Turkish family medicine specialist who lives in Şanlıurfa, Turkey. I couldn't be with you today due to the earthquakes in Turkey. As state of emergency was declared in the affected provinces, Şanlıurfa being one of them. This meant that all leave was suspended for civil servants until recently. This, coupled with the clogging up of bureaucracy, meant that we couldn't get a passport for my daughter in time. I really wanted to be with you today. I had been excited for a long time to participate in my first WONCA conference. So I was very upset when it became clear that I wouldn't be able to come. But the thing is, I couldn't even allow myself to be upset. Not when people were dying, losing loved ones, losing their homes around me. Not for a trivial thing like a conference. The same thing was true for being upset about the cracks in my house. Not when I passed by people living in tents every day. Not when colleagues were living in their cars with their families. I couldn't feel sorry for myself for being in a constant state of anxiety and fear for my daughter. Looking to the door with every little vibration and making plans in my head on how to grab her and run. Because I was the one that had to prepare the report on the baby that died under the collapsing building in our province. I had to come through the autopsy report. I had to take the father's statement because the mother had also died. So, what right did I have to be upset? I realize all this may be a little dramatic, but it's actually not that different from what I've encountered, what I've been through since coming to work here 2 years ago. Şanlıurfa is a province in the southeast of Turkey with very deep-rooted issues. I can't get into all of them in the limited time that we have, so I would like to focus on gender inequality issues. Now, I'm personally sensitive to gender issues, but I think for anyone coming to this region for the first time, gender inequality would be the most striking issue. I've seen so many tragic situations that I thought were a thing of the past, that sometimes I wonder if I'm actually in a bizarre alternate reality. For example, we all read about child brides when I was in Istanbul, where I was born and grew up. But to us, it was just that, unacceptable stories from faraway lands. So things got very real very quick for me when a 17-year-old kid came to my family health center for the state-mandated pre-marriage health exam, along with her much older fiancé. They told me that they had already kids, plural, and wanted to make things official now, that she was legally of age. Another woman in her 30s came to me to seek advice on how she could secretly have an abortion, because her husband wouldn't let her, but she thought her body couldn't take it anymore after 6 children. Another time, an anemic pregnant woman which didn't respond to iron supplement therapy. After some digging, it turned out her mother-in-law didn't let her take any medicine because they would harm the child. Then there was a teenager, aggressively asking me to prescribe acne medicine, which I found out she planned to use to harm herself because her parents wouldn't let her go to school. These examples are just the ones off the top of my head. I've had many similar encounters in the limited time I've been here. So even though I'm a person who likes to complain about things, I've been put in my place countless times and have had to face the fact that I've relatively been living a very privileged life here. But hey, it's not all doom and gloom. I saw the people come together after the earthquake, helping each other out any way they can. With the extraordinary effort from the rest of the country and abroad, rebuilding is going strong, piece by piece. People have adapted to their new situation, as they always do. I saw how resilient people can be here. When we first came here, I was stressed out about the mortar bombings of our province by terrorists. My husband, who works near the Syrian border, can hear the sounds of war from his family health center. But now, after 2 years, we don't think twice about it. Although our situations are incomparable scale-wise, I imagine the Ukrainian people must be going through similar situation. Humans adapt to anything after a while. They accept the reality of their situation and keep on going. The fact that we as a species can take anything life throws at us and keep on going gives me hope. There are also things that give me hope on the gender inequality situation, although I believe that is far more difficult to solve than any natural disaster. Things like an illiterate Kurdish man who had trouble expressing himself in Turkish, trying to excitedly tell me about his daughter's school success. And how she wanted to be a doctor like myself. Or my family health center staff being nearly all women, who were all local except for me. Or the fact that the woman I mentioned earlier being comfortable enough to come to me for help. In spite of the language barriers and some lingering mistrust of the state and the region. This last point especially fills me with hope for the future and also pride, to be honest. It highlights the special place we as family physicians have in the community. It shows, at least for me, how we can be force for good in addition to our roles in providing healthcare services. As I conclude my words, I would also like to mention the help of the EYFDM family. Even in the bleakest of times, I felt their support, and it gave me strength. Even though I have been far away from friends and family these past 2 years, I've never felt alone, thanks partly to the European Young Family Doctors Movement family. I've always known the importance of international cooperation, but to experience it on such a personal level was very humbling. So, thank you. Thank you all for listening. See you next time, I hope.
So, yeah, what can I say? Does anybody want to comment on anything that Ikbal said before we go to the Slido? Okay, so we thought Ikbal's words are very powerful, and I think some of the things about gender and health inequalities particularly. But I think no matter where we work, there are definitely health inequalities which we should not accept. So if you could take up your Slido. Yes, this one. And take the photograph, please. Would anyone like to speak about any of the things that they put on their Slido? Yeah, please do.
Hi, my name is Elena. I'm from Spain and I work in the UK. I wanted just to comment two things. Something that it causes me a bit of rage happened like 2 weeks ago, no, 3. A patient called the surgery. I work in England, and a patient called the surgery, and she said she wanted to speak with an English-speaking doctor. And the receptionist said, "Well, they all speak English. What do you want?" And then she said, "Well, you know what I mean," which is quite a racist comment in my understanding. And the other thing that I wanted to show or to tell, about what Daria was saying, is that if I remember right, there's a BMJ study from 2021 saying that actually doctors underestimate the gender gap. So yeah, maybe some food for thought. We don't see what we have apparently. If anyone is interested on that, I can show you the study, or I can give you more information on that. But thank you very much for this session. It's been brilliant. Thank you.
Thanks, Elena.
Hi, I'm Rishi from the UK. I'm a GP trainee. I just wanted to say that I from a trainee perspective, having talked to many trainees, I think apathy and forgetting about the mission of general practice family medicine is that we're meant to work towards achieving health equity. But that's not a conversation we typically have as trainees. It's really considered implicit in our curriculum, but it's not really made explicit. I think one of the starting points is actually for trainees who are going to be future general practitioners, family medicine doctors, to actually remember the roots of general practice family medicine.
Thanks, Rishi. Does anyone else want to comment on this topic before we move on? Yeah. So, yeah, thanks for bearing with us. I know we've presented things that frustrate us, not always the most positive things, but we try to find hope there. And the last Slido question is to look, I guess, towards where we go from here. And a positive question about when you feel you're at your lowest, personally or as a family doctor, what do you remember that helps you stand up again? Okay, I think because I skipped back, it's not going to work. So, can you guys see it on your phones? No. Okay. Okay, it's there. Okay. Let's see what's coming. And I think what Rishi was saying about the mission of being a family doctor, even though sometimes it's very stressful with workload and the other challenges, I think most of us can remember that what we do is very worthwhile. So that would be my 2 cents. Okay, so that's all I really have to say. Daria, do you want to say anything to conclude?
First of all, thank you everybody. You have been like so many of you here. It's really a pleasure to have talked in front of you. I hope that what you will get from today is, as Ikbal also has said, that it's not all gloomy, and that it's like very refreshing to see that we have like so many young and a bit older doctors as well. We are all conscious of the fact that there are difficulties, there are challenges, there are crises in family medicine, but the fact that you are all here today means that you also want to do something about it and you want to make a change. And you can keep in mind that even like small changes can have like a butterfly effect. connect, and it was like so nice to have this discussion with you, have this brainstorming, and look like all of the things that you can actually put into place, that we can actually put into place after only 2 hours of discussion. So imagine what we can do if we actually put ourselves into it and make it like in a sustainable way. So thank you very much.
And I will just add that I noticed quite a few of the suggestions were go to WONCA, go to EYFDM events. So this is your chance. So if you scan the last QR code, you can enter our lottery. And we have a registration for Australia, 3 for Dublin pre-conference, 3 for Dublin main conference, Vienna, and the money that you donate in the lottery goes to bursaries for EYFDM members from lower income countries to join us next year. So thank you for your donations, and yeah, have a nice evening, guys.